I think people are still filing in, but I'm going to go ahead and get started so we don't get behind. This is a very interesting topic, and we've got some wonderful speakers, so I would like to get started. Good morning. Is it still morning? Yes, I think so. My name is Tara Calder, and I am the director for the USIDNet program at IDF. You guys have all been to sessions already, and you've probably heard this, which I am contractually obligated to tell you. Before we get started, I want to talk to you about the surveys we conduct to evaluate your IDF National Conference experience. You should have received a pre-conference survey, so we thank you for filling that out. We will also be notifying you of a post-conference survey, where you can provide feedback on this session and all the sessions that you've attended. After the conference, you'll receive either a notification in your conference app or an email. So we thank you in advance for filling that out because it really helps us understand the true impact of what we do here and to so that we can focus our efforts on what is best for you. Questions will be answered at the end of the talk. Please write your questions on the cards or paper that you have. Colleen in the back or I will come around and collect them. Just hold them up as you have something. And at the end of the talk, we'll give them to the presenters to answer. Now, it is my great pleasure to welcome you to Understanding Immunoglobulin Therapy. I've been talking all day. You don't have to tell them that. This session will be presented by Dr. Mark Ballow and Dr. Elizabeth Younger. Dr. Ballow serves as an allergist and immunologist within the University of South Florida and is a member of the IDF Medical Advisory Committee. Dr. Younger serves as assistant professor within Johns Hopkins University School of Medicine and is a member of the IDF Nurse Advisory Committee. Please join me in welcoming Dr. Ballow and Dr. Younger.
So I get the pleasure of presenting the first part, and Elizabeth is going to follow up about halfway through. These are our disclosures. Because we have a lot of relationship with some of the products that you are using, either as a speaker, advisory boards, or data safety monitoring boards. So what is immunoglobulin? And some of this may be kind of a repeat for many of you because you've gone to other sessions that have kind of addressed the same issues, but that's okay. So it's derived from the serum of, I'll say, normal subjects, in which they pool together the plasma from these individuals. The FDA says between 1,000 and 60,000 donors per lot. Usually it's around 10,000 plasma units that get pulled together into one lot. The FDA restricted it. I don't know, I'm sure some of you remembered around 2000 there was a marked shortage of gammaglobulin, and that's because one of the products was quarantined for reasons which I won't get into. But because that particular manufacturer used more than 60,000 donors, they had to quarantine a lot of gammaglobulin, and that led to a shortage. For those of us who write for this product, that led to a lot of stress. There was actually committees in hospitals that decided, believe it or not, who gets gammaglobulin and who doesn't get gammaglobulin. We're smiling because we remember those days. Fortunately, today we have plenty of gammaglobulin available. There are many different products. There are new products coming online almost every couple of years from different vendors. Anyway, immunoglobulin is highly purified IgG. If you look at the package insert, you should ask the physician, by the way, for a copy of the package insert just for your own information. It's about 95 to 99% pure IgG. It has other plasma proteins, including small amounts of IgM and IgA, and as I said, small amounts of other plasma proteins as well. I think you know that there are no preservatives in gammaglobulin, so that if you're doing infusions at home by whatever methods, intravenous or subcutaneous, you need to make sure that the bottle or bottles that you pull out of the shelf or refrigerator are not cloudy. They're nice and clear and they're not discolored. Because there's no preservatives in them. And I imagine once in a while you get into a defective cap, which may let in perhaps some air and some other impurities that could change what the gammaglobulin looks like. So if you're doing it at home, even if there's an infusion nurse that helps you with IV, make sure you look at the bottles before you use them, that they're supposed to be the way they're supposed to be. Although there's no preservatives, there are stabilizing agents. Most of the products use amino acids, either proline or glycine, but some also use sugars as well. And the purpose of these stabilizing materials is to prevent the gammaglobulin, the IgG, from aggregating. Because if it aggregate meaning clumping together, then particularly with the IV route, it could cause adverse reactions. And that was a particular problem with some of the older products back in the 80s and 90s, where they were lyophilized and not liquid. Today, I personally use only lyophilized products. I think there's only one, liquid products. I only use liquid products, not lyophilized products. There's only one lyophilized product, I believe, that's still on the market, and all the others are liquid. So we've made some significant advances with regard to changing from lyophilized, meaning powder, lyophilized is freeze-dried powder products, where you have to reconstitute it, and using liquid products. So one story I'd like to tell is that one of the home care nurses had difficulty getting a lyophilized product in solution, so that individual thought it was a great idea to put it in the microwave to try to enhance the solubility. And that definitely aggregates the IgG, so that when it was administered to the patient, they had a severe reaction. So we don't have to deal with that anymore, so that's good. So the FDA defines a little bit more what immunoglobulin should be. It must contain all 4 immunoglobulin subclasses in approximately the same ratio as we all have in our serum. The half-life has to be the same as our own half-life, approximately, here it says 21 days, 23 plus or minus days in general. It has to maintain its biological activity, and they measure that by various functional assays. And then they talk about the donors that possibly have underlying viral infections like HIV, hepatitis B, hepatitis C, need to be excluded as donors, and I'll get back to that in a minute. And the plasma collected itself should be screened very carefully for these particular viruses, as well as some other viruses. And the manufacturing process is such that if there's any possibility of one of these viruses kind of sneaking through the donor selection and the plasma selection process, that there should be methods to actually destroy or remove the viruses. The plasma that's used for the generation of gammaglobulin or immunoglobulin must be collected in the United States. So let me embellish a little bit of what you see on the screen. First of all the plasma is derived from plasmapheresis. That's a process by which a normal individual comes to a plasmapheresis center and they withdraw large amounts of blood. They spin it and give back actually the cellular elements like the red cells, etc., and then just recover the plasma part. That's a little bit different than how it was done in the 80s and 90s, where patients donated a unit of plasma and then the whole thing was separated by the Red Cross into the red cells, the platelets, and the plasma to generate immunoglobulin. These plasmapheresis units are not in large cities. They're usually in smaller towns and cities, college towns, where they can draw upon a younger population that potentially have less risk factors for some of these viruses that we're concerned about. There has never been a case of HIV transmitted by gammaglobulin. It's just fortuitous that the first manufacturing step for making purified gammaglobulin is something called ethanol fractionation, cold ethanol fractionation. You all know what ethanol is, obviously. And that luckily inactivates or kills the HIV virus. So there's never been a case, even back in the 80s and 90s when we did not know what the etiology of AIDS was, no patient ever got HIV from gammaglobulin. Now that's not true for hepatitis C and some of the other hepatitis viruses. So the manufacturers, together with the FDA, came across, well, they actually developed some very, very strict guidelines in selecting donors, including risk factors. They obviously tested their serum for these particular viruses by looking at antibodies as well as the actual viral RNA or DNA in their serum. The other thing that kind of was an important step in the safety of gammaglobulin is that if a donor comes in to donate through plasmapheresis a unit of plasma, they would hold that unit again. They would hold that unit until that individual came back for a second plasmapheresis. And only then, when they were tested a second time, would they release the first unit of plasma for use in the manufacturing of gammaglobulin. And the reason why that is because when a donor comes in, they could be within a window period when they don't or haven't yet made antibodies to that particular virus, like hepatitis C virus, and therefore we wouldn't really know whether they're infected or not. So that's why they hold that unit. The manufacturers and the FDA, again, I think you'll notice there was a partnership between the manufacturers and the FDA to try to make gammaglobulin as safe as possible. So the other things they did was to try to change the manufacturing process to ensure that if any of these viruses snuck through, that they would be removed or inactivated. And obviously that's solvent detergent. So you'll see that some of them have SD. That's solvent detergent. Some of them are, one product is pasteurized. Again, it's the same process of trying to remove any potential contamination. I already talked about the ethanol as the first step, removing, possibly viruses like HIV. And finally, around the year 2000, and because of what was happening in Europe with the mad cow disease, the manufacturers introduced steps called depth filtration, ultrafiltration, nanofiltration to remove large particles, including prions, which was responsible for mad cow disease in the UK. So I tell, this is a very frequent question I get from patients. How safe is gammaglobulin? And of course, I can't say 100%, but I can say it's pretty darn good products that we have today. They're pretty safe. They've they've really changed between 1985 and present day. The manufacturers have done a really good job of ensuring as safe a product as possible for patients with PI. So how does it work? Again, I'm sure many of you know this. It contains specific antibodies against a broad range of bacteria and viruses because it's pulled from a large number of individuals, as I said, on average around 10,000. These antibodies are capable of either neutralizing the potential pathogens or neutralizing their toxins. These antibodies also participate in a process called opsonization, which is just a technical term for the ability of the white cell to phagocytose or eat certain pathogens, particularly bacteria, like the ones we worry about all the time, strep pneumonia or Haemophilus influenza and bacteria like that. The immunoglobulin preparations obviously increase serum levels of IgG. Since it's 95 to 99% pure IgG, it does not change the levels of IgM or IgA. So who needs replacement therapy? This is a list, probably a partial list of patients who definitely needs immunoglobulin replacement therapy because they have antibody deficiency disorders. So here's where I kind of give a little bit of editorial advice. There's been a lot of advances in the past 5-10 years on identifying new genetic mutations that are associated with various types of immune deficiency disorders. So, for example, one of the most common antibody immune deficiencies is common variable immunodeficiency. And we now recognize it's kind of a mixed bag, but we now have been uncovering some of the genetic etiologies for this particular disease of common variable immunodeficiency. Why is this important? Although we do get pushback from insurance companies to do genetic analysis, is because if we can demonstrate that there is a gene associated with your particular primary immune deficiency, we don't have to go through the rigors with the insurance company to try to prove to them every couple years that you have an underlying immune deficiency disease. That still remains to be a challenge and a fruitless exercise on our part. So there are other diagnoses in which immunoglobulin may be beneficial. Again, this is only a partial list, but the underlying gold standard, I talked about this yesterday as a matter of fact, the underlying gold standard is a deficiency in the ability of that individual to make specific antibody. So it may not rely so much on the serum levels of IgG, but whether you can make protective specific antibodies. And we had a discussion yesterday about Pneumovax, and I'm sure you've been to other sessions where they've also talked about that as well. Obviously, the goal of therapy is to provide protection against infection, both bacterial and viral infections primarily. So what are the options for therapy? And that goes with not only the product, but also the routes of administration. Again, a lot of this I'm sure is familiar to you. IVIG every 3 to 4 weeks, subcutaneous, and then there's a lot of flexibility. Most patients do it either once a week or once every 2 weeks. And then there's another it's similar route of administration, subcutaneous, but we call it facilitated subcutaneous, in which the addition of hyaluronidase allows larger volumes to be placed in the subcutaneous tissue so that we can actually do it every 3 to 4 weeks subcutaneously. So the site of care, and this should be a discussion between the patient and the physician or physician extender. And of course, they're listed here. IVIG can be done at home, obviously in a hospital or an infusion center, like a cancer center that has an infusion center. Subcutaneous immunoglobulin can be usually administered at home. The facilitated subcutaneous immunoglobulin is at home. It can be done in a physician office, depending on the physician. I'm not aware that it's actually being used in a hospital. I know we've had discussions with various formularies in the hospital, and they have rejected it so far. So I think the facilitated subcutaneous is either home or in a physician office. And this, again, I said this already, but the decision on brand and on the type or route of administration is really a collaboration between the physician and the patient to decide what's optimal for them, given their lifestyle and other elements that may impact on the decision making. So. I'm sorry? That's it. Okay. So you want me to go through this list? Or is that you? That was my last one. Okay.
We've done this before, and it's always dangerous to let him go first, so I gave him a cutoff. Anyway, so the decisions that Mark talked about and the things that you need to think about when you want to do therapy is how long an infusion are you willing to do? Are you willing to do an IV infusion that may take 3 or 4 hours and you have that kind of time and that's okay for you? Or do you want to just get it done and get it over with? What route works for you? Do you have Can you think that sticking yourself with a needle is the last thing you'd ever do on earth? There are people like that, and just, I have people that say, you could lock me in a closet. I will never stick myself, and I'll die in the closet because I'm not coming out. Just not happening. So that's important. So other decisions, can you do it yourself? Do you want to do it yourself? If you don't want to stick yourself, you don't have to stick yourself. There's no terrible thing about not wanting to stick yourself. Side effects are a big thing to think about. There's a lot of people, not a lot of people, I shouldn't say that because gammaglobulin is much better these days than it was, but there are people who definitely have side effects, systemic side effects with IV gammaglobulin. They don't have those side effects with subcutaneous gammaglobulin. That might be an important factor for you in your decision making. Again, where do you want to do it? Are you comfortable doing it in your home? I have a gentleman who does his subcutaneous infusions in his car when he drives to work every Monday morning. Works for him. Is one way better than another? That's a conversation you need to have with your physician. Sometimes you may have another problem in addition to your immunodeficiency, which might lead your physician or your prescriber to push you toward one method or another, because there are sometimes other things to think about. Is there a cost difference? Huge, huge these days. Nobody knows what the insurance landscape is going to look like tomorrow, next week, next month, even next year. So you really do need to consider, what's this going to cost me? What's the potential for what it could cost me? And if I go one way or one place over another, is there going to be a cost difference for me? And the bottom line, the most important question, is what's right for you. And you are the only one who lives your life, and ultimately, that decision is yours. Okay, then. I like this crowd. I don't have to get on my soapbox. I also told the interpreters I'd be kind and not use long words they had to spell out, so I'm trying. So, as I said, understanding the differences and all of their options, whether or not there's a clinical significance for you, whether those things are pros or cons, should absolutely be determined by you and your prescriber. What's a pro for me may be a major league con for you. I'm a little bit of a control freak, and I want to be in control of everything in my life. Maybe you're the opposite extreme, and you want people to come to you and wait on you and not have to make any decisions. We have therapy for you. Okay, so let's talk for a minute about efficacy. So all immunoglobulin products are equally efficacious. In other words, all of them have the ability to provide you with that prophylaxis, protection against infections. But some patients may need a very consistent level of IgG. When you give IV gammaglobulin, you have a high peak, and then over that half-life, the level of IgG comes down. You get another dose, it goes up again, and it comes down, and you've got what I call the roller coaster phenomenon. When you give subcutaneous gammaglobulin, you put a small amount of drug someplace where it's absorbed very, very slowly, so your level of IgG looks like this instead of like this. It's a little bit like if you have a bucket with a hole in it and you want to keep the bucket full of fluid. If you only fill it up once a week, that fluid level is going to go way down. If you fill it up constantly, you can keep the bucket full even though it has a hole in it. So that's a conversation that you need to have with your provider. Do I really need a very consistent level of IgG? Do I have what's known as the wear-off effect if I'm on IV gammaglobulin, and right before my infusion I just start feeling crummy? I have a guy who says, I don't even need to look at my calendar to know I'm due for an infusion. I wake up with a runny nose, I'm tired, I just don't feel well, and I know I need my infusion. So for people with that kind of sensitivity, maybe a more consistent level is a better way to go. But you need to know that IV or sub-Q drug is going to buy you the same protection. That's important. And then as I was talking about, maybe you have other things besides your immunodeficiency. Do you have problems with your kidneys? Everybody knows IV gammaglobulin is a large volume, and it can be a hit to your kidneys. Will you do better with a smaller amount of drug more consistently? If you have inflammatory bowel disease and you lose protein every time you stool, immunoglobulin is a protein. So if you get an IV dose and you have bowel disease, your levels are going to go down much more quickly than someone who doesn't have bowel disease. So are you a person who benefits from that constant replacement? There are people sometimes who have neurologic issues, people with Parkinson's disease who have problems with kinetics and have problems giving themselves infusions. If you're one of those people, then maybe subcutaneous infusions aren't right for you. Maybe you need someone to do your therapy for you. Mental health issues are a big thing. I have a patient with terrible high blood pressure, and she says, well, I forget my high blood pressure pill 3 times every week. Well, that's a blood pressure pill. Am I going to think that she's going to do subcutaneous infusion if she can't remember to take a pill? Probably not. That might not be the person I think is going to do subcutaneous infusions. But those are things, as I said, that you need to think about, whether they're problems or not. They deserve some consideration. So the products on the market, this is probably redundant, So IV products are 5%, 6%, and 10%. And the concentration is all about the volume. So obviously a 5% product is going to be twice the volume as a 10% product. Subcutaneous products are 10 or 20%. And again, it's all about the volume. Can you give yourself 25 cc's of a 20% product? That's 50 cc's of a 10% product. And the facilitated subcutaneous product, there's only one on the market, and that is a 10% product. So other things to think about. What's your life look like? Do you have some consistency in your life that you're going to be able to do an infusion on a consistent basis? Are you all over the place and no day is like any other day? might be something to think about. I always have a discussion when I send my kids off to college and remind them that somehow infusions are going to have to fit into their college schedule, which sometimes is hard when you're having pizza at 2:30 in the morning and you're sleeping till 10:30, and oh, by the way, you have a bio lab from 1 to 5 on Tuesday afternoons. Who knows? IV access is also a consideration, and we always say a port is never an option for an immunodeficient patient. The academy that oversees allergy and immunology, what we call Quad AI, the American Academy of Allergy, Asthma, and Immunology, and the Clinical Immunology Society have both adopted guidelines, and very clearly does it state in the guidelines that ports are not appropriate for immunodeficient patients. So if there's difficulty of IV access, that might be someone we might gently nudge towards subcutaneous infusions. So let's talk a little bit about side effects before I want to make sure we leave time for your questions. Most people tolerate immunoglobulin really well and can fly around like Mickey, but there are some people who just get knocked on their buns when they get their gammaglobulin. There's absolutely a spectrum. The good thing to know is that we can deal with whatever side effects happen. So side effects with IV gammaglobulin can happen during the infusion. They can happen after the infusion. During the infusion, people can get nauseated, they can get chills, they can have blood pressure changes, just feel crummy. True allergic reactions to gammaglobulin in immunodeficient patients are very, very, very rare, but still a possibility. More frequently, after the infusion, people have issues. They get that post-gammaglobulin headache that comes 12, 24, 36 hours after the infusion. Some people get muscle and joint pain, and some people just get extraordinarily fatigued. I remember when I first started doing this, I had a lady who said, "Oh, I always get my infusion on Friday because then I sleep all weekend." And I was like, "You sleep one weekend every month? Does that work for you?" That blew me away. I was like, maybe we need to look at your routine and what you're doing and see if we can fix that. There can be an inflammation of the covering of the brain, aseptic meningitis. That's an inflammation without infection, which can also be caused by IV gammaglobulin. And generally, there aren't local reactions. So the nice thing to know is if any of those things happen, we generally can treat it. Normally, we go back and look at the infusion and what happened during the infusion, and can we fix things. Sometimes we need to slow the infusion down. Sometimes you got it a little too quickly and you couldn't tolerate that rate of infusion. Sometimes you weren't well hydrated. We know that hydration is critical before giving gammaglobulin. We can always change the product. Nowadays we have lots of products that we can play with and change if we need to. For whatever reason, sometimes people just tolerate one product and not another. We talked about how they're all virtually the same, but it's a little bit like ice cream. Haagen-Dazs is way better than Ben & Jerry's. Just saying. But if you're a Ben & Jerry's fan, go for it. But that's essentially what is equally true of gammaglobulin. And sometimes we can pre-medicate with some Tylenol, with ibuprofen, and sometimes a little bit of a spit of a short-acting steroid can beat those side effects. And again, for the post-infusion issues, again, a little bit of steroid may help take care of that headache. Any serious side effects, we're mandated to report to the manufacturer. You should know that. For subcutaneous gammaglobulin, the side effects are very different. Very, very rarely do people have systemic side effects to sub-Q gammaglobulin. But there's a but, because there's always a but. You do have local reactions. Basically, you've got fat cells that are lined up like a brick wall, and that gammaglobulin is pushing these fat cells aside. And they're doing some pushback. They don't want to move readily. So they do some pushback, and your body's like, whoa, what is this stuff in my system? So your body tries to reject it. So what happens? White blood cells rush to the area. You get red, you get swollen. The nice thing to know is that the first infusion that you do subcutaneously is always the worst. Your body gets used to it over time, and those reactions, those local reactions, definitely decrease over time. And I have people that have done sub-Q gammaglobulin for years, and they say, oh yeah, I did my infusion last night, and I'm like, where did you put it? There's not any redness, there's not any lump. I can't see where they put their infusion. So that's a good thing to know. You kind of, when you teach people, you got to say, you got to give me more than one time because you're not going to do it if you only do it once. Give me time to work through the issues and give your body time to get used to what's going on. So treatment of sub-Q side effects, the important thing to remember, it's a local reaction, so you're going to treat locally. Sometimes people want to rub it, put a little bit of heat on it. Other people, they're a little itchy and they want to put a little cold, a little hydrocortisone. I tell my patients, go for it. Whatever you think you should do, do it. The important thing to know is that when you give yourself subcutaneous gammaglobulin, it's not what we call biologically available to your system for at least 24 to 36 hours. So it's pointless to do any pre-medication because this drug isn't in your system yet. I have a couple people who still get a smidge of a headache after a sub-Q infusion. What I do is I give them their Tylenol or their Motrin after their infusion before they go to bed, and then again the next morning, and that usually nips the headache problem in the bud. If problems persist, then you have to have a conversation with your prescriber, with the people who taught you to do your infusions, because that's a sign that something may need to be changed up. Maybe you're allergic to the adhesive that you tape down the needle with, and changing from a Tegaderm dressing to just a piece of adhesive tape takes care of the issue. Sometimes there is a need for a product change or a rate change. Those things need to be worked on, and you need to realize it's an evolutionary process, and it's not necessarily going to be perfect the first time, and you may need to play in order to get your infusions exactly right for you. Okay, so this is our take-home message, and I think we're right on time. Good. So just remember that your immunoglobulin therapy is part of your life. It should never, ever be your life. It needs to fit into the life you want to lead. One size doesn't fit all. If I asked everyone in the room who's on gammaglobulin to stand up, however many people are here, I guarantee that every one of you does things a little bit differently. You may have a different product, a different rate, a different route, a different frequency. I guarantee you all do it a smidge differently. And go for it. It's important that you do that because, again, it's part of your life, not your whole life. And the only truly, truly right way to get your therapy is to get it the way that's right for you. And that's my soapbox. Am I on? Right. Perfect. He divided them. That means he got to choose the good one. In that case, I'm going first. All right, so the question is, this person's been considering switching from IV gammaglobulin to sub-Q. Is it advisable to do sub-Q once weekly or even more frequently in order to reduce the load and peaks and troughs? Again, this is what I addressed about 4 or 5 slides ago. There are no peaks and troughs with sub-Q gammaglobulin. You have a level of IgG that sits here like this and stays very, very, very consistent. And if I had an easel and a graph, I would show you a lovely chart that shows you people who are giving themselves a little hit of subcutaneous gammaglobulin every single day and people who are giving it every 14 days, and the levels look exactly the same. So if you want to do it every day while you're brushing your teeth and push 5 cc's of gammaglobulin, do it. If you want to do a little bit larger amount and do it every 2 weeks, do it. There's not going to be any effect on your IgG level. Your turn. Yes, sir.
Is there a concern for not having enough plasma donors? No, I don't think so. I think I haven't heard any issues. Is this on? I haven't heard any concerns about plasma shortage lately. What differentiates one product from another? How do patients know what is best for them? Well, there's no lab tests. There's no label on a product that tells us, which patients may tolerate one product from another. We don't know that, a patient may tolerate product A but not product B. So there's no way of telling. Physicians, however, will go with what their experience is. So, for example, if I use mostly product A and my patients have good results and they tolerate it, I may suggest going with product A to the home care company. However, if infusions are done in the hospital, I don't have that choice because there's a formulary. Usually hospitals have a preferred product on formulary with a backup product, and there I have no leverage, essentially. So the patients get put on product A. If they have problems with product A, then obviously we go to product B, which usually works out okay. But there we have no control.
So I have a question. What's the difference between SCIG and facilitated SCIG? That's about a 5-minute answer, but let me do it in about 30 seconds. So facilitated subQ gammaglobulin, you administer an enzyme called hyaluronidase. You push it before you do your facilitated subQ. And the purpose of that is to, in effect, break down the collagen matrix in the skin so that the skin cells spread aside and you can put a larger volume in one area. So basically, that's the major difference. And the secondary question, does facilitated subQ require a nurse? It does not require a nurse. Patients can be taught to do it themselves. However, the process of starting facilitated subQ is actually a 7-week or 7-infusion process because you start slowly and build up, and it's a 7-week ramp up. So generally that takes a nurse to get until you're up to snuff, as it were. That's HyQvia, yes. The product is a Shire product. So I have another question. My 14-year-old son gets, quote, horrible, underlined 14 times, headaches 48 to 72 hours after his IV infusion. He misses schools. Any suggestions on how to alleviate these? And then she says she pre-medicates with Benadryl and Motrin or Tylenol. First thing I would say is how hydrated is the child before he or she gets his infusion? And I would uber hydrate the day before. I would consider a product change. I would consider pre-medication with steroid, not Benadryl, not Tylenol, but pre-medication with a short-acting steroid before that infusion. Those were and the rate also I would consider, how fast I was infusing. I would look at all of those parameters and, again, play with those parameters to try and beat this. Nobody should get gamma-globulin headaches in this day and age. Pardon, can you overhydrate? Yeah, I guess you probably can. You can get water intoxication, but yeah. I can't imagine that's the case.
Your kidneys are working.
Her kidneys are working, yeah.
So is that IV or what route?
This was an IV.
Yeah, but so that I would suggest switching to subQ.
Yeah, I'd switch an IV.
Now that's not 100% with preventing headaches, but clinical trials, and there's many clinical trials now comparing IV with subQ, all show that the incidence of headaches is much less and more mild than the IV route. Because after all, you're infusing a large bolus of protein with the IV route. So that I'm sure it plays a role, and that's why hydration is important.
Let me just do a quick follow-up to it, because this is another facilitated subQ question. It says one of my slides talking about places for therapy. It says that facilitated subQ needs to be in a home, hospital, or infusion suite. Does that mean that you shouldn't do facilitated subQ when traveling? Why not? The issue is that it takes a high-volume infusion pump, which is not. Those of you who are in the room who do subQ gamma globulins probably use what's called a Freedom 60 pump, because that's what most insurances pay for, and that's a pump that's not even the size of a shoebox and weighs less than a shoe. But you need a high-volume, regular infusion pump to do facilitated subQ, and the volume you're giving yourself 3 or 4 weeks of a 10% product. So that's not a 50 cc bottle. That may be 200 or 300 cc's. So I am not the world's expert on HyQvia, but I would imagine traveling while you're on HyQvia could be a little bit difficult, and you might need to juggle your infusion schedule and your travel schedule a little bit.
I was told that when plasma was donated, the first donation and tested, it was dumped, and the second donation was then again tested and used. Remember I mentioned that before. No, it's not dumped. The first batch or donation of plasma is set aside, frozen of course, and held until that patient comes back for a second plasmapheresis. And then if tested negative, the first plasma unit is released for contributing to a lot of gammaglobulin, so it's not dumped. Can you get autoimmune condition from subcutaneous product? I don't know how to answer that. I've never seen that.
Yeah.
I've not seen it reported. Now, you know, there are patients with antibody immune deficiency that do have a variety of type of can get a variety of types of autoantibodies from cytopenias, in other words, like low platelets or low neutrophils, or autoimmune endocrine problems or GI problems, and that's just part of their underlying primary immune deficiency disease and not related to the administration of immunoglobulin replacement.
So somebody had a skinny kid who's having a very difficult time with sub-Q gammaglobulin. He likes IVIG, but he can't keep his numbers steady. My suggestion would be to talk to whomever taught you how to do sub-Q and look at how you're doing it and where you're putting it, what sites you're using. My personal favorite site is the hip, not the abdomen, because everybody's got, pardon the demonstration, a little pad of fat right here, right beneath the hip bone. It's not, pardon me, your butt, it's your hip. And I actually have a patient who's a baseball catcher, so he's got thighs like tree trunks that are rock hard and gorgeous six-pack abs. This is the only place he's got a little pad of fat. And the same story, I have a ballet dancer. Same story with tremendous muscular legs and no tummy to speak of. But everybody's got this pad of fat right here. And the easy way, the landmark is if you look over your shoulder, you have to be able to see your hand. If you can't see your hand, you're back too far and you're using your, pardon me, butt. It's absolutely your hip, and that's my favorite spot. Even the skinny miniest people have that fat pad, and I move people to that site, and people are like, whoa, the light went on. So that's how I beat it for my skinny mini people.
Great, good suggestion. What's the difference between CVID and gammaglobulinemia? Obviously, we're talking about immunoglobulin replacement, but just briefly, gammaglobulinemia just means no serum immunoglobulins, no IgG, no IgM, no IgA. A patient with CVID can be gammaglobulinemic. However, some clinical immunologists refer to gammaglobulinemia as patients who have a clearly defined genetic abnormality called X-linked gammaglobulinemia, in which they were born with no B lymphocytes and again no serum immunoglobulins. But so it's just a matter of terminology.
We can get one more. We're running out of time. Anything they don't get to, we're going to collect, and they'll be answered on the IDF website after time.
And we're not going anywhere. You can buttonhole, certainly me. My last question is going to be, I know people who get headaches on IVIG, but less so with sub-Q. What about nausea and vomiting? Basically, it goes back to the slide. Systemic side effects with sub-Q drug are much rarer than IV drug. As I said, IV, you're putting a large amount of gamma globulin into the system, right into the circulatory system, and it's swishing around very, very quickly. So it's shooting that IgG level way up high. And those side effects are because of that high IgG level for the most part. Not completely, but for the most part. You don't have that level with sub-Q drug. Your level's here. So systemic side effects are much, much rarer. And I will tell you, I have well over 400 patients on sub-Q drug, and I don't have anybody who gets nausea or vomiting associated with that infusion.